Thank you, sir, for the nice words. It's a pleasure to be here. And as I was just saying that it's actually quite surprising, but it is my first visit to this huge facility and well-known facility, other than through patients and other than the friends. We've been connected for a long time, but it's really a privilege and an honor. And I'll be talking something that is of my interest, but it is true that the overlap between osteoporosis or metabolic bone disease and liver hasn't gotten enough focus, neither in endocrinologists and I don't think even in hepatologists' perspective. While MASLD and all have become like a sort of unifying condition for endocrinologists and gastroenterologists, hepatologists, and even some cardiologists to work together, bone disease in liver patients has sort of taken a back seat. Of late, there has been huge focus on bone disease in diabetes, which also wasn't emphasized till about 10 years ago. And quite remarkable data have come out on the importance of screening people with diabetes for bone disease, and they seem to have 1.5 to 2 times greater risk of fractures simply by having diabetes. And you know, diabetes is so common in India. Just to say that there is a whole emerging area. And today we are going to talk about cirrhosis and liver disease and the relationship to metabolic bone disease and osteoporosis. So this is, as I said, a silent complication of chronic liver disease. So just to clarify, I was just discussing with my friends. I made my normal slides on a blue background with dark blue background with white and yellow text. And my team insisted that times have changed. And they have redone the slides 3 days ago. So they're very dramatic slides, but the message is the same. So this is the silent complication of chronic liver disease, basically because osteoporosis per se produces no symptoms, liver disease or not. So the issue is that it's a little bit like LDL cholesterol. You know, you unless you measure it, you won't know it, right? It won't produce any symptoms till you finally get a heart attack. So similarly, osteoporosis is a silent disease which eats away the bones, and you will only know when you get a fracture. So sometimes our orthopedic colleagues insist that there are symptoms, but no, if you don't have a fracture, then osteoporosis per se won't produce a symptom. Of course, if you have osteomalacia, it's a different thing. We'll talk about it. So hepatic osteodystrophy is a metabolic bone disease common in chronic liver disease, manifesting as osteoporosis or osteopenia. And all of you, I'm sure, are aware of what we mean by osteoporosis and osteopenia. These are measures which are evaluated on bone densitometry using DXA. And there, when the T-score goes below minus 2.5, it is called osteoporosis. And when the T-score is between minus 1 and 2.5, it's called osteopenia. So both of these are common in liver disease. It's under-recognized, under-treated. And it is different from typical postmenopausal osteoporosis. For decades, the field of osteoporosis was stuck only with postmenopausal women, which of course is the most important group. But over the years, people realized men and so many other medical conditions where osteoporosis became very, very important. But early diagnosis, like in all chronic conditions, is important so that we can prevent damage and prevent fractures. The single goal is to prevent fractures in our patients. So to understand a little bit, I'll have to take you back to this really old slide, but these things don't change so much. This is the bone remodeling cycle. So this is the surface of the bone. The other cells that are just resting there. Nothing is happening. And then they get activated. What happens with their activation? They become large, multinucleated giant cells, which are osteoclast. And they come from the mesenchymal stem cell. We won't go into all that. But they chew up part of the bone, right? And this takes about 7 to 10 days. And then there is a formation stage, which takes about 10 weeks. Our teaching is 10 days to eat up, 10 weeks to build. Destruction is much easier than building. So it takes only 10 days for the osteoclast to eat up that part of the bone, and it takes 10 weeks for the osteoblast or the bone forming cell to fill that space up. So I think this is a very important concept. And if there is these are two processes that are linked. They are linked all the time. So if you lose bone, you will also make more bone. In a normal, healthy, physiological state, if you lose bone, you will make bone. So this is the process that is happening in the bone. So somebody may ask, why is this crazy thing happening? I mean, if you're going to lose and make and lose and make, why are we doing all this? So there are two reasons. There are many, but there are two broad reasons. One reason is that our bones are susceptible to micro damage. All the time micro damage is happening. So we don't see it, but our bones will develop micro damage spots, little damage spots because of wear and tear, normal wear and tear. So what do the osteoclasts do? They scoop out the diseased part or the damaged part, the bone resorbing cells. And the osteoblasts fill it with new cement. So you are constantly repairing your bone. And the process of scooping out and the process of filling up is balanced. That is called coupling. So when this coupling breaks, so either the bone resorbing cells, the cells that eat up bone, osteoclasts, they are hyperactive. So you chew up more bone, then the osteoblast can't fill up enough cement. Or the osteoclasts are doing their normal job, but the osteoblast or the bone forming cell is weak, so there is less cement to fill up. So either the scooping is too much or the filling is too little, then you get osteoporosis. That is the coupling that breaks down. So what happens when estrogen declines? You get acceleration of bone resorption, bone scooping out, bone loss, and the bone formation is not able to keep up. So you lose bone. So this is important to understand, without which we can't really go further. Now what has changed in this recently is the concept. Okay, so now there are conditions where there is a high turnover of bone, which means, as I said, a classic example, of course, is typical postmenopausal osteoporosis, where lack of estrogen produces a rapid turnover. So lot of bone loss is happening and the bone formation is not able to keep up. That is high turnover osteoporosis, typical osteoporosis. But then there are conditions like when we use corticosteroids, or in liver disease. In liver disease, the predominant pathology is low turnover osteoporosis, which means it is the formation that is impeded more than the resorption. As I said, there are two components, losing and making. Losing and making. Now, it's the losing component that is classically increased, but in liver disease, it's the making ability, the building ability that is more affected. So therefore, it's a low turnover disease. The whole bone turnover goes down. You're not able to form enough bone. So this is the first concept, is that it is a low turnover osteoporosis. It's different from postmenopausal osteoporosis. And just to emphasize here that osteoporosis and osteomalacia are distinct. For this audience, it's not really relevant, more for surgeons and all orthopedic surgeons, that when you actually have D deficiency or calcium deficiency, where mineralization is seriously impaired, then that is osteomalacia. You've heard of rickets, of course, soft bones that bend, or osteomalacia, which still happens in India, and you get people who can't walk with their weak bones and all. That is osteomalacia. But the classic osteoporosis is asymptomatic, where the bone mineral is normal, but the amount of bone has gone down. So you can see the difference in the two sides. This is loss of bone mass, but mineralization is okay. In osteomalacia, the mineral is seriously deficient. So most common cause of osteomalacia in India is obviously nutritional vitamin D deficiency. So when you have serious vitamin D deficiency, then mineral doesn't reach the bone. Another very important condition for all of you will be celiac disease, where D is not absorbed properly, and therefore you get significant osteomalacia. So these are the things that are important to understand. And what about the prevalence of the condition? Actually, if you look at just the bone density part, then 35-40% in different studies of osteopenia, osteoporosis. The only point worth emphasizing is that it's very high. These studies are also little confusing because some have used different criteria, whatever. But consistently, the numbers are about 50%, 35%. They are in that range. They are not in the 2-5% range, right? So Low bone density is common in patients with liver disease, especially, we're talking chronic liver disease, cirrhosis and that group. It seems that alcohol, because it has other effects also, particularly on the cholesterol transport, etc., alcoholic liver disease had even worse bones than our MASLD. So while both are important, alcoholic liver disease produces even more bone damage than other causes of bone disease. Of course, you're all aware of primary biliary cirrhosis and the bone disease. That's been understood for a long time. But that we're not talking about that today. We're talking in general about cirrhosis. So obviously, then there is an increased atraumatic fracture risk. You know, again, this is very obvious, but osteoporosis means that your bones break without sufficient trauma. Without anything happening, without a car accident, without you really falling down the stairs, just tripping on the road, just walking like this, or just leaning your arm, or sometimes even not that in old age. The bone just cracks. That is osteoporosis. So non-traumatic fracture is what we call. And different studies again have shown different fracture risks depending on what criteria of liver disease they have followed. So this is a very heterogeneous mix. But again, it is high. It is definitely more and more studies showing in double-digit percentage, even the fracture rates in people with cirrhosis. This is an Indian study, so I put it there. So just saying that osteopenia or osteoporosis, again, more than 50% people. Half have osteoporosis, other half have osteopenia. Enough to remember. This is in different studies. Again, I won't go too much into that, but the point here is that primary biliary cirrhosis you all know, but also alcoholic liver disease is a very important cause of osteoporosis. So what exactly is happening here? We'll again revise this, right? Resorption followed by formation, right? Now, what has changed in this this is a 1999 slide, but what has changed in this is what triggers the start? How does this cycle get activated? That was not understood. That, okay, there is micro damage. Why? What triggers it? What is the process that triggers it? And there, the role of osteocytes come into play, and I'll explain that again. But again, if you're looking at overall hepatic osteodystrophy, let's spend a little time on this slide. If you look at the uncoupling of bone turnover, I think that's very, very important. Uncoupling of the same thing that I explained, that bone turnover is coupled. The amount you lose to the amount you make is the same, but there is uncoupling. That happens because, this is very important, osteoblast activity is suppressed, which means bone forming activity is suppressed, right? And there is pro-inflammatory cytokines that also increase bone loss activity. So you are suppressing bone formation and little bit also increasing the bone resorption. There is direct cellular toxicity, hyperbilirubinemia, you know very well, iron overload, again in specific situations. What is the molecular and cellular target? It's the rank OPG axis. We can't explain that today, not enough time. But important that unusual fibronectin, the oncofetal fibronectin, that also inhibits bone formation. So what are we looking at? We are looking at suppression of bone formation, which happens because of many things, including hyperbilirubinemia, including iron overload, including unusual fibronectin or abnormal fibronectin, and systemically by other things like hypogonadism that is so common in liver disease. If you have testosterone deficiency, you will get osteoporosis, right? And also now increasingly IGF-1, the growth hormone deficiency, that is common because IGF-1 is generated in the liver and you would get trouble there. But do not forget, of course, the common factors which I will again explain. This is the overall effect, the pathophysiology of hepatic osteodystrophy, meaning that it's predominantly a bone formation issue, but there is also adverse impact on bone resorption. So reduced formation and increased resorption. This happens at various levels because of various causes, including systemic causes like the hormones that happen or direct effects of liver-produced toxins. What has changed here, just a little bit, and this is important because what has been shown in the liver situation also, and this is quite recent, is the role of sclerostin. I was telling you we don't know what triggers the cycle, the remodeling cycle of resorption and absorption, resorption and formation. So there were these cells which lie within the bone surface. So you heard just now of the large osteoclasts that eat up the bone. You've heard of the plump, small osteoblasts that form bone. But there's a third group, osteocytes. If you read literature till about 5 years ago, even 7 years ago, osteocytes, no one knew what they did. They're just dead. They're just dead cells lying embedded in the bone. But actually, osteocytes are the mechanostat. So when there is a little damage to the bone, it's osteocyte that triggers, that releases substances that triggers this remodeling. And that is very important. And they make a substance called sclerostin, which is actually against anti-bone. Just to remember, sclerostin is not good for osteoporosis. Sclerostin will increase bone damage by its action on osteoblast and primarily on osteoblast, but also on osteoclast. So sclerostin is a substance that is very important now because it's a mediator of bone damage. And therefore, newer therapeutic approaches in osteoporosis in general are sclerostin inhibitors. If you can inhibit this, you will release the osteoblast from its suppressive effect. And you will sort of reduce the osteoclastic activity. So dual-acting drugs that act via sclerostin are very, very important. And this sclerostin has become a key point even in hepatic osteodystrophy. So now, most important is osteocyte release of sclerostin. That triggers hepatic osteodystrophy. So if osteocyte releases more sclerostin, then you will get more osteoporosis. So that is one thing we need to understand. That is a new concept. And this is one more that I'll discuss before we go on to the management and diagnosis part. The others, I've already talked about trophic factors, IGF, alcohol, iron overload. One important factor, of course, that we should not forget is vitamin D deficiency, which is very common in India and particularly common in patients with liver disease. They may have some hydroxylation defects also. So it's important that vitamin D deficiency is adequately treated. Because if you have D deficiency, you will certainly have bone problems at some point or the other. And of course, vitamin K also, which plays a role in bone mineralization. So all these are contributing factors. It's very hard to put all of it in one simple way. But the important points to remember are, as I said, the effect on the bone remodeling cycle and the main mediators of that, the main factors, and the actual process, which is now more and more thought to be due to sclerostin. So a new pathway in this is the reverse cholesterol transport. That's interesting. So basically, if there is more cholesterol in the bone, there is greater risk of fracture. Fat bone will become a weaker bone and fracture more. So there is a process by which, and again I won't confuse you, the process by which cholesterol comes out of the bone, right? If that process is impaired, then you will get more osteoporosis. So I think this is an important part that you need to understand, that even reverse cholesterol transport is a factor, and therefore drugs are being tried which will enhance this throwing out of cholesterol from the bone into the blood so that the bones become stronger. That's the therapeutic area that people are working on. So these are the two new concepts that one should take home. One is that sclerostin is important, and the second is that reverse cholesterol transport is also very important in determining bone disease in liver disease. And of course, the other factors we already know, the gonadal hormones, the vitamin D, and all the other issues. So then what should we do clinically? So body mass index is the most powerful predictor. You will be surprised, even now. Low BMIs in chronic liver disease actually predict osteoporosis and fracture. Again, if the BMI is high, beyond say 30, that also is not good for the bone. So there is a band in which BMI is good for the bone. A healthy BMI, overall healthy BMI, is the one that will protect your bone also. We classically were always taught, and you may also have been taught, that frailty and very lean individuals, but we also realize that there is a lot of obesity with sarcopenia. So people who look okay or not really okay. But anyway, without going into all that, BMI has been shown to be an important predictor. The BMI, a low BMI as well as high BMI, both, but low BMI more studied than a high BMI, is clearly a predictor of osteoporosis and fractures. Obviously, the rest are very obvious on the right side. Those are the general risk factors. Women are more prone than men. Age is a single most important factor, non-modifiable. Alcohol, smoking, severity of liver disease, and of course steroid use, which is so common in so many conditions, not just liver disease. So all these will identify that this person is more likely. You need to be super cautious about that. So one approach in this is, of course, to do the bone density, and then that we'll talk about. But even before doing the bone density, if you don't have access to bone density for everybody, for example, for economic or other reasons, then one can do a clinical risk score. This, unfortunately, they put up the UK thing. There's an India FRAC score also. This is a clinical risk assessment tool. Much debated, much fought over in every meeting of ours all the time. But nevertheless, at the moment, we have nothing better. So this is the clinical risk score, which tells you based on clinical parameters, age, sex, weight, height, previous fracture, parent history, smoking, steroids, rheumatoid, all these things. There's a FRAX plus also in this. But anyway, so there are clinical risk score without a bone density, which will tell you which patients to investigate further. So if the clinical risk score is below a particular level, you will probably wait and say, don't have to do anything, wait. Okay. Of course, this clinical risk score validation for liver disease has not been done in India. This is based on Western data, what I'm going to tell you, but it gives you a trend that this is how it's going to be. So using FRAX for screening is a concept, and not everyone will 100% agree. Some people will say everyone needs a bone density. But going to facilities where, this may not be available all the time, if you do a clinical risk scoring and you use a score of 6.6%, right, then you will label people as osteoporosis. Now, it does not mean that if you have this score and you do a bone density and then the patient just requires treatment, you still have to look at other risk factors to decide treatment. Otherwise, you'll end up treating everyone with anti-osteoporotic drugs. So, screening test, what is screening test. So, the FRAX score can be a clinical screening tool for you. Sitting in the OPD there's an app you can download, it takes like 30 seconds, not even that much, because those are very easy things to fill in. And you can decide, well, this person does require a bone density, and then interpret based on the bone density and the other risk factors. So this is the way that FRAX in clinical, there's increasing sort of discussion of developing FRAX-like tools more and more for our population. We have a FRAX for India, but it's not the most refined. So that, we cannot expect bone density to be used for all our postmenopausal women or high-risk people. So having clinical risk scores will actually be very, very helpful for us. And this is the one that is used. Australians use their own, but this is the one used in the rest of the world. Of course, you all know about bone density. You all know that a T-score of minus 2.5 is considered diagnostic of osteoporosis, but there are many caveats. I don't want to confuse you or bore you, but 50% of fractures occur when bone density is better than 2.5. In general, this is not talking of liver disease. So, but it is still the best marker we have. So again, despite all the fights and the debate, still continues to hold ground as the diagnostic criteria. Okay, so minus 2.5. And between 1 and 2.5, minus 1 and minus 2.5, you will call the patient osteopenic. And below minus 2.5, you will call the patient osteoporotic. You all have seen this. You use this regularly. Now, the challenge in liver disease is this, that ascites is a major confounder. Okay, we know that obesity is a confounder sometimes. That it affects the bone density measurement. But quite clearly, just ascites tapping makes a difference to the bone density measurement. So this is very important for you guys to know, because I think you will have a lot of patients who come with significant ascites. So it's important that someone has significant ascites. Please, before paracentesis, avoid doing a bone density, or you can't interpret it properly. Ideally, You may still have to do it in some patients where ascites won't go away, but it's ideally it should be done when there is less fluid in the abdomen. Otherwise, technically, the machine it makes an error there. So just to explain, the ascitic fluid will change it completely. Look at the right side. So the technology is not good enough to adjust for ascitic fluid. The other parameters that are now being used, and more in India also, is the same bone density machine has software for something called trabecular bone score. It's not difficult. It's calculated from the images of the DEXA itself, but the software is a bit expensive. So many hospitals don't have it, especially purely paid hospitals, because you'll have to get the patient to pay more for the software. So this is important, because when we are measuring bone density by DEXA, we are only measuring bone quantity. With TBS thrown in, it gives some idea of the bone architecture. And especially in systemic disease like diabetes, and I'm pretty sure in liver disease, now more and more evidence that you need TBS to predict fractures rather than just using the bone density per se, but doesn't require a separate machine. Same machine, just adding some software. The TBS is the sort of gradually becoming the norm in all these things. And one thing that I always do when I'm screening people for osteoporosis, our policy in our unit is that anyone over 60 with diabetes, especially if it's 10 years history of diabetes, we always do a bone density. And when we do a bone density, especially in those over 70, but even those over 60 actually, always do a lateral spine X-ray. Because the bone density can mislead you if the vertebrae are compressed a little bit. Asymptomatic compression is not uncommon. Not uncommon. We did many years ago a study in Vasant Kunj, which we published as the Delhi Vertebral Osteoporosis Study, DVOS. And that actually showed through the RWAs, people who volunteered or agreed to get a bone density done, we found pretty high, 15 to 20% people above 65 had some degree of minor vertebral compressions. So there it's important not to depend on the DEXA alone. This is simple. This is not difficult, doesn't cost much. Lateral spine X-ray is important, or you can use more sophisticated software that is available on the machine. Again, you have to buy it, like a vertebral fracture assessment. But simple plain spine X-ray is really helping us. Lumbar spine lateral. Okay. So you will find that everything looks okay, but the patient has a little compression here and there. You have to do those measurements, and we can discuss that. Harry Janant built that classification. It's not difficult. It's not difficult at all. Now, what about bone markers? So this is all radiology. What about blood tests in liver disease and bone disease? Classically, in osteoporosis, we use something called CTX, cross labs. आपने देखा होगा cross labs का report कभी-कभी from more sophisticated labs. We use a lot of cross labs for us in managing osteoporosis has over the last 3-4 years become like HbA1c for diabetes. It is very important to follow when you're treating people, not in diagnosis, but in treating people. But cross labs, and that is a resorption marker, osteoclast marker, and P1NP, which is a formation marker. Even if you don't remember that, the important thing for you is that they don't work well in liver disease. So that is a problem. In chronic liver disease, you have to look for other markers. People are looking at other markers and other imaging techniques. I told you trabecular bone score. But even in the markers, they are looking at other things because those markers don't work so well. They're affected by liver disease. We use them a lot in people without liver or kidney disease. Unreliable markers, P1NP, CTX, you may use, but they're not. You have to be very cautious in interpretation. The preferred marker in liver and kidney disease is a bone-specific alkaline phosphatase, which has just become available in a few labs in Delhi. I don't know how good it is. We haven't really done studies on it, but it is available. But it is supposed to be a better marker in kidney disease and also in liver disease. So you will screen your patients clinically first. You will send them for bone density if required. Then you will use criteria for treatment. And for their monitoring, you will, when you're sending for bone density, ideally you can do a trabecular bone score, that will help. The bone markers that we commonly use are not very useful. So ideally we wait for the time when bone specific alk phos becomes a routine thing. We used to do it in a very crude way when we were younger, and heat bone specific alkaline phosphatase and all that. That used to be heat labile and not heat labile, but all that is really very inaccurate. So what about patients with liver transplant? There is a big issue there, and we have done some studies on liver transplant patients, and obviously with all that is happening with the transplant, along with the chronic liver disease, you have a huge risk of fractures. This is grossly ignored. It took me a long time to convince my nephrology colleagues that they are not looking at the bone health of their patients. They are looking at graft survival. Of course, that is first host survival, graft survival. But when they have 10-year follow-ups now, 15-year follow-ups now, then their bones are crumbling. So when you have chronic, survival improves, then obviously other things play in. So both in liver and kidney transplant patients, bone disease is a big issue, because most of them are on corticosteroids, in addition to all the other risk factors that we've already discussed. And the important point here is that all that we taught earlier is wrong, because most of the bone loss occurs within 6 months after transplant. And we always say that, wait for 1 year, see bone loss, and then start treatment. So there's a fundamental flaw in what we have been teaching. If you have to treat patients with bone transplant to prevent their bone loss, you have to pick those up early, pre-transplant, and initiate treatment either pre-transplant or immediately post-transplant, because their bones are going to get worse for sure. So I think this is very, very important that we look at it. We did some studies in Medanta, and then this is straight off the thesis, which has been submitted like last week or something. The DNB exam is about to happen. So the prevalence of osteoporosis and osteopenia, again, 1/3 were normal, 95 post-liver transplant patient. This is cross-sectional, not a very sophisticated study, just cross-sectional bone health of patients who've undergone liver transplant, right? So you find 1/3, 1/3, 1/3. 1/3 are osteoporotic, 1/3 are normal, 1/3 are osteopenic. I'm not showing you data about how age influenced it and all that, but also fractures. There were 11 out of those 95 who had fractures, right? So it's important that 11 is quite a large number, tallies with the world data. And of course, immunosuppressants and corticosteroids. So what I'm saying is that post-liver transplant bone health is a very important area, which sometimes gets lost because you're dealing with so many things, so many complexities, that you forget it. It's not that hard. And a little look at the bone health parameters would really help you prevent fractures in your patients who are now living so long. I mean, and fortunately, with all the advances in hepatology and what you guys do, you have, chronic liver disease is not a diagnosis that is, like a dismissive diagnosis now. It is a lot of good outcomes. So it's good to remember that this also needs to be looked at. So what should we do if we do diagnose someone as requiring treatment, right? We've screened, we've tested by whatever measures we have done all the risk factors and everything, and the patient does require treatment. Now, normally we just treat, right? There are set criteria, but there are issues in liver patients. Of course, there's issues in your case. Most important is that there may be significant esophageal issues and gastric issues. So that, of course, is a concern that we shouldn't aggravate that in any way. So I think this is important, that we realize that gastro barriers may be there. Many of your patients may be having renal issues. Hepatorenal, to double ho gaya. Then there's a barrier because of the liver and of the kidney. Barriers meaning barriers in choosing treatment, because drugs can get affected or may have more side effects. And then of course we have to look at our better understanding of what is causing the condition, and at some point, I'm sure it's going to happen, we'll be able to identify those who have predominantly bone formation issues, treat them differently, and treat those who have predominantly bone loss issues differently. But it's not reached that stage yet. But that is the future. So why we are cautious in liver disease? Obviously because of gastrointestinal and renal issues. you do not forget vitamin D repletion, do not forget calcium, magnesium, and maybe some patients require calcitriol instead of this thing, but not most people are still able to make enough 25D if they are given in good amounts of cholecalciferol. So one point, a couple of points here which I can't resist but explain is that vitamin D levels, normal levels that are marked by our labs are grossly wrong. A vitamin 25 hydroxy D level of 20 to 40 is quite normal. If you're a little fussy and a great believer, then 30 maybe. But our labs say 30 to 100 normal. 100 is borderline toxicity, and above 90 you can easily get toxicity. There is no data to suggest, proper data, to suggest that those kind of levels help. In fact, they may worsen something. So, for practical purposes in your patients, when you see these reports of 28 nanogram, 24 nanogram, be cool, that's good. That's fine. So, vitamin D deficiency is a huge problem in India, but now over-treatment has become a problem. And some of my younger colleagues tell me that you have unleashed a monster. By telling everyone is D deficient, people are over-treating and we are getting such high levels. We don't need those high levels. 20 to 40 nanograms. In nanomoles, it will be 50 to 100 nanomoles. That is perfectly fine. Okay? So, important to understand. And what is the best way to do that? Maybe 2,000, maybe in liver patients 3,000 IU per day. Using large doses or injectable is not recommended unless there is an absorption issue or something. Because high levels of D may have their own issues, especially in the risk of falling and all. So, maintaining, like in everything in medicine, in a human body, maintain in the ideal band. So 20 to 40 is a good level, up to 50 is also okay. But no reason to panic at a level of 25, 30, that you come here, borderline low hai. You know, I keep getting these calls and these referrals which make no sense. So I have spoken to the pathologist association. I'm hoping somebody will listen and they will actually revise their what they write as normal in the reports. And we have the several drugs to treat osteoporosis. Bisphosphonates remain the mainstay in chronic liver disease also. Bisphosphonates remain the mainstay. They are the most commonly used drugs. We have the largest experience. They are like the metformin of diabetes, but a little bit more caution is required. What do bisphosphonates do? You saw those large cells eating up the bone. They knock out those cells. Bisphosphonates are poisons for osteoclast. They knock. So bone resorption reduces substantially, and therefore people get improvement in their osteoporosis. Denosumab, very popular. Prolia and other brands now very popular now. It's a powerful anti-resorptive. Less data in liver disease, but whatever data is there is encouraging. The challenge with denosumab is that it is when you take it off, when the patient goes off the drug, there is a sharp rebound. So when you remove it, you have to substitute with some other drug for some time. So it suppresses bone resorption and boom, it goes back up the moment you stop it. That doesn't happen with bisphosphonates. The anabolic HRT we leave, and anabolic agents are the PTH analogs, teriparatide, and romosozumab, which we have fair experience with now, but I don't think there is much data in liver disease at the moment. But it might be because romosozumab is an anti-sclerostin drug. So maybe the future might be there. So if we look at these drugs carefully, bisphosphonates are used as oral agents like alendronate once a week. But as you know, some of them may have issues with gastritis and other things. So therefore, intravenous zoledronic acid has become more or less the norm. 5 milligram once a year. 5 milligram once a year zoledronic acid given slowly is quite safe. 10 to 15% people get a flu-like reaction with intravenous bisphosphonate. So that can be prevented by giving either 2 days of steroid or 2 days of NSAIDs, whatever is easier and preferable. But bisphosphonates are the mainstay. Denosumab in selected cases. What about the PTH analogs on the right, which are also very popular? And fortunately in India, they are not expensive because there are a lot of generics available. PTH analogs are bone-forming agents. Now we're working on the other part. Now, when we are saying that the main problem is low turnover and bone formation, the future might see more and more of the right side of your slide. The teriparatide, PTH, and romosozumab. But at the moment, the data is limited. But it is thought that those who have a low bone formation markers, they are good candidates for teriparatide. That is given as a daily shot for 2 years. Daily shot for 2 years, not 2 months, not 3 months. Very difficult to explain to surgeons about that you need to give a drug for 1 year or 2 years. But I think it's important that we give it minimum 1 year, preferably 2 years. That is teriparatide PTH analog once a day with a pen, easy to inject like insulin, and for up to this period. So at the moment for you, the default mode is bisphosphonate, but more and more use of anabolic agents. This is how they act. We won't go that. These are clinical trials in cirrhosis, but very limited. Very limited. We won't. Last few minutes. How do we take decisions? And just some sample patients. 52-year-old lady who has PBC, the kind of patient you will see. We don't see that much. Grade 2 esophageal varices. Bone status is a T-score of minus 2.8 and 2.1. So this patient has osteoporosis. So what should we do? Challenge here would be that either we can use oral bisphosphonate, or you can use, the patient doesn't really have fractures and all. So, or you can use intravenous bisphosphonate if you're concerned about the varices and the, and the irritation, etc. So that is one part. So this is a good candidate, straightforward. The second one is an alcohol-associated cirrhosis, who's now abstinent, of course, and who also has CKD. Now this is a problem because the T-score is low. There is some rib fracture, doesn't really classify as osteoporosis, but something. Severe osteoporosis, minus 3.1 is quite low. eGFR is low. This is our nightmare for us when such patients are referred, because no drug is really safe. That's the problem. So, patients we discuss with the nephrologist, hepatologist, and try to decide, because the patient is just very likely to fracture, So, again, in this, we can either use bisphosphonate, very slow infusion, and half dose. Now, this is not published studies, but everyone I have met across the world does similar things. For patients on with significant renal or hepatic disease, you can use low dose intravenous bisphosphonate, or very slow. At least you'll be doing some benefit. But there should be actually a head-to-head comparison of low dose versus normal dose, but it's not there at the moment. So you do use that, or optionally, some people go for denosumab in such cases, which is renal and hepatic safe, but the issue of the rebound you have to take care of. You have to have a compliant patient who takes the injection every 6 months. Denosumab, Prolia, is given every 6 months sub-Q. उसमें 6 का 7 महीने हो जाएगा तो प्रॉब्लम है. तो उसमें you only can use it in people who are going to take it at 6 months and be compliant about that. So these are the two options. But let me tell you, treating chronic liver disease, osteoporosis in patients with CKD can be very, very difficult, because everything has an issue. These drugs, both the bisphosphonate and the denosumab, can produce hypocalcemia. There are other risks also. So you really need a specialist in this kind of situation to figure out and what to do. A little bit of, juggling without solid evidence may have to be done. And the last case here is a 45-year-old listed for liver transplantation who has a Z score. Now he's young, so his Z score is, you measure a Z score in those who are below 50. Minus 3.5, 3 vertebral fractures. What do you do? This guy, ideally, I would like to treat with teriparatide. Teriparatide or PTH is very powerful for vertebral osteoporosis, those who have prevalent fractures. Now that we understand liver disease fractures are more linked to bone formation, giving anabolic drug is better. I suspect this is the way it's going to happen more and more in the future. That we'll be using more of anabolic drugs for such patients. But this case, if this patient came to me, we would use teriparatide. Ideally, I would try to get a bone-specific alk-phos done. Agar wo ho jata hai, nothing like it. It further strengthens our thing. If bone-specific alkaline phosphatase, which is a marker of bone formation, if that is low, further strengthens your resolve to use a bone-forming agent. So to summarize, screen all cirrhotic patients, assess clinical risk factors, low BMI, alcohol use, smoking, hypogonadism, female sex, advanced age. Easy. You'll do that in any case in everybody. Utilize FRAX, possibly. This is one approach. I can't say this is a final approach, but you can use clinical risk factor scoring. And if you're below 6.6%, you may avoid bone density. Or if you believe and you have the facility and it's not that expensive, you can use bone density for everybody. Okay? And if you, and also at the same time, you must assess for vertebral fractures by at least doing a lateral spine X-ray. Do a trabecular bone score if available. So use the standard criteria for diagnosing osteoporosis once you reach this. And remember the ascites story. Don't forget that. And everyone requires D and calcium. Pharmacologic therapy I have discussed in detail. And re-evaluate bone density after 1 to 2 years. Don't keep doing the bone density frequently. Definitely not earlier than 1 year. So that is another mistake people make. One is about D level, other is about repeating bone density and saying there is no response. Comparing bone density is also a challenge. You really have to sit with both the images properly and compare because the differences are very minor. And if the bone density positioning or placement of the marker, anything is off, then you can't really compare. So same machine, ideally, same institution. I mean, same machine, same brand and same machine also. That really makes a difference. So I think we'll stop here, and if we are careful, then this is a picture I recently took in Bangalore. This is called a foxtail palm. But anyway, it stands straight and tells us how we should try to keep our spines despite all the issues and all the problems that we face. Thank you so much.